about the airways to know that inserting anything in the mouth risks breaking the teeth. And if you break the teeth off, of course, they may aspirate them, and that would be disastrous, besides that you've broken their teeth off. So you almost never need to put anything in the mouth. If it seems as though they're not breathing well, then a simple jaw thrust is usually sufficient. Rarely you'd need an oral airway. And during convulsive motor activity, it's almost always a bad idea to put an oral airway. Why? Because if they're going then you can hear they're moving air, which is typically the sound during convulsive motor activity. And if they're moving air, you don't need to do anything to their airway. Now, it may sound like they have an upper airway obstruction, but as long as they're moving air, it's better if they move some air than you break their teeth off. Suctioning of secretions is important. So typically that means rolling them to the side or the head to the side so secretions can come out or be suctioned. And typically rolling them onto their side would be helpful. Oxygen is rarely needed. We typically would provide it, but it's actually rarely needed. And finally, circulation is usually not a problem because they have hypertension and tachycardia and increased glucose as a result of the tremendous convulsive motor activity, because the same time they have the convulsion, they release a tremendous amount of adrenaline. So their blood pressure might be high and they might be tachycardic, but that's appropriate and doesn't need to be treated. It's important to note the start time of the seizure because, as we'll talk about, longer seizures have greater chance of causing death and require a different kind of treatment. And finally, monitoring their oxygen saturation is prudent because, after all, you don't know why they had a seizure yet, and maybe it's something that might lower their oxygen saturation. It's important to monitor their EKG because occasionally they can have arrhythmias, particularly if they've gone on to have impending status epilepticus or if the seizure's gone on more than 30 minutes. And finally, it's important to monitor their blood pressure because if their seizure or convulsion started from some kind of circulatory problem, a myocardial infarction or arrhythmia, then of course they could have hypotension that goes along with that. Partial seizures are different though. Because they don't have that tremendous motor activity, they're not nearly as problematic from a medical point of view. So it's important to stay with the patient, but not to restrain them unless it's necessary for their protection. It's important to try to get them to sit down. As you saw in the video, the nurse, maybe it wasn't within the video, but what the nurse had actually done outside the framework that I showed you is try to get the patient to sit down. But when she wouldn't, she didn't force her to sit down. Instead, she just stayed with her. Often important to hold on to the patient so you can control them, and also, if the seizure secondarily generalizes, you want to be there to catch them. Often you'll arrive to the scene after the seizures happen. Another name for seizure is ictus. So after the seizure, we call that the post-ictal period. And during the post-ictal period, the first response to a convulsion is different than a partial seizure. After a convulsion, the patients can look agonal. They look like they're about to die because they're lying there totally, entirely unresponsive. They're hypotonic. They have slow, deep respirations. Sometimes the respirations are agonal. They have lots of upper airway sounds. So they look terrible, but in fact, they're likely to recover very quickly. Their pulse and blood pressures likely return to normal. And afterwards, they have a very deep sleep, sometimes for hours. But even though they would like to sleep for hours, they're almost always arousable within 30 to 60 minutes. So the key after a convulsion, so let's imagine arriving on the scene in which the family says they just finished having convulsive motor activity. Probably not quite so directly, but you deduce that, and they seem unresponsive. And the most important thing to do is to see that they're continually getting better, waking up gradually over the next few minutes. That's different after a partial seizure, because after a partial seizure, they may be confused, but they're not unconscious. This can be very important. It's important for first responders like EMT, medical responders like EMT, but it's also important for police officers because after a seizure, people may be confused. There are many, many cases of people who, after partial seizures, were arrested for their behavior. About 3 years ago, there was a man in Washington, D.C. who was riding on the bus. He had a seizure, and part of his seizure activity was to grab things. So he grabbed the leg of the woman sitting next to him and held on very tight, which of course she screamed. The bus driver stopped. They called the police. Man didn't run away because he's busy having a seizure. Afterwards, he was confused, so when the police arrived, he can't tell them why he did it or where he is or even his name for a few minutes. Consequently, they arrested him. He actually was tried and convicted, and then it was overturned on appeal when they recognized that it was a seizure. So it's important to recognize that people can be confused after a partial seizure. They may talk incoherently, they may grab, hit, sometimes wander or often wander, and sometimes run, which can be very problematic. So it's important not to restrain them and to talk to them calmly. The acute seizure treatment medically is really none if the seizure lasts less than 5 minutes. You don't really need any intervention. You don't need to give them benzodiazepines, don't need to do any kind of medical intervention except to observe them and do the things we just talked about. However, If it lasts more than 5 minutes, we have to treat it as impending status epilepticus, which is a medical emergency that requires immediate intervention. So what we're really asking you to do is before 5 minutes, hands off. After 5 minutes, dive right in. And the reason is because status epilepticus, as I'll talk about in a moment, is a different animal that has much more chances of causing problems. During an acute single seizure, though, injuries are common, such as muscle strain. Almost everyone's sore after that. Occipital laceration, because as I mentioned, they fall like a tree with unprotected falling. They can dislocate a shoulder, have vertebral fractures, occasionally cause suffocation, which is very sad. Rarely there can be cardiac arrhythmias, either as a cause of the seizure or causing the seizure. And there are a couple of common mistakes to recognize that some of which I've kind of touched on, but one important one is that giving sedating medications for a self-limited seizure is not a good idea. And the way this occurs is that the patient's seizing, the rescue squad arrives, they draw up what their lorazepam or diazepam, they're about to give it to the patient, they stop seizing. And they think, well, I guess we might as well give it anyway to prevent the next seizure or for some other reason. And the answer is better not to, just to wait. Because once you give the lorazepam or diazepam, then the patient will be sleepy and unresponsive, and now you don't know if they're sleepy and unresponsive because you give them medication or because they have ongoing seizure activity without convulsive motor activity. So better not to treat if it's a self-limited seizure. In previous years, we said that was the rule. So that 20 years ago, I had a mentor that said, the first thing to do when you see someone having a seizure is go get a cup of coffee, because it was going to do more harm from intervening than not. I wouldn't go that far, because by the time you arrive as a first responder, they've probably already been seizing 5 minutes. But nevertheless, it's important once they stop to recognize they stopped. A second common mistake is intubation for transient postictal unresponsiveness. So if someone's sleepy and stuporous after a seizure, then it's not a good idea to intubate them. It's better if they're breathing on their own just to monitor them. If they need to, you could bag them for a few minutes because they're really likely to wake up in 5 minutes, and better to bag them for 5 minutes than intubate them and all the complications that go with that. So you really shouldn't intubate unless there's a need that's persistent and not transient. Of course, it's important to control the airway after the seizure. Now let's turn to what happens if the seizure goes on for more than 5 minutes. What if they have impending status epilepticus? So the historical definition is 30 minutes, but now the current definition is only 5 minutes. And the reason is because if you wait the whole 30 minutes before you provide intervention, then by the time you're done providing intervention, it's already been much more than 30 minutes, and you've already increased the chance of death and other complications. Whereas if you start after just 5 minutes of seizure activity, then you have a whole 25 minutes to stop the seizure before it causes injury. Now there's another reason, and that's because we know that most seizures stop in less than 5 minutes, and if they don't stop in 5 minutes, they're unlikely to stop on their own. I'll talk about that in a moment. Now there are some subtypes of status epilepticus. What I've been talking about is generalized convulsive status epilepticus, GCSE, and that's more than 30 minutes of convulsions or recurrent convulsions over 30 minutes without return of normal consciousness. And the key there is that they're having generalized motor activity, as I've suggested, for 5 minutes, but formally for 30 minutes. But there are other kinds of status epilepticus in which convulsive activity is not a part of it. This is non-convulsive status epilepticus. And this is all other kinds of ongoing seizure activity. It has many categories. It can look like repetitive complex partial seizures, or one long complex partial seizure with staring and confusion. Sometimes it's called ictal stupor or myoclonic status. It can be found in intensive care units on EEG, even when the patient isn't moving at all, for instance, which wouldn't really be your concern. Sometimes it's called subtle generalized status epilepticus, in which patients are unresponsive with just an occasional jerk. And the reason to bring this up is because anytime someone is unresponsive, you have to consider status epilepticus. There'd usually be certain specific situations, like they just finished having a seizure, a convulsive seizure, or they have epilepsy or other concerns, but it's important to recognize it. Most of my comments will be aimed at GCSE because that's a real consistent medical emergency. So once again, how has the definition of GCSE changed? Well, most seizures last less than 3 minutes in an epilepsy monitoring unit. Most seizures in children last less than 10 minutes. So it's a little longer in children than adults. But those lasting more than 10 minutes in children are really unlikely to stop spontaneously. Therefore, a proposed practical definition of GCSE is seizure activity lasting more than 5 minutes. Now, instead of remembering all these numbers and considerations, I think we can say, at least for almost all of us who live in Virginia, it's going to take more than 5 minutes for someone to pick up the phone, call first responders and first responders to arrive. So a practical definition is that by the time the EMS arrives to someone, if they're still seizing, that's probably impending status epilepticus. I mentioned before that in a retrospective review of seizure duration in an inpatient video EEG monitoring unit, that the average total seizure duration was only 62 seconds, and the range was 4 to 107 seconds, so that we can safely say seizures lasting more than a minute and a half are pretty unusual, at least in an epilepsy monitoring unit. Status epilepticus is common. There's 126,000 to 195,000 episodes of status in the United States. The peak incidence is in early childhood in the elderly. So in those more than 60 years old, the incidence is about 100 per 100,000 population. In children less than 1 year old, the incidence is about 325 per 100,000 population. And about 40% of childhood status occurs in those less than 2 years old. So what does that mean for practical terms? It means that most people with status are very old or very young. And this is sort of that illustrates the distribution. So you can see in those less than 1 year old that the incidence of status is very high in this graph, and those over age about 40, but particularly over age 60, is much higher. Now let's think about what causes people to die during status epilepticus. Well, first of all, the most important thing is what's causing it, the etiology. That's the most important determinant of etiology, but also age. The older you are, the more likely you are to die. But also seizure duration. Now what's important is that you can't change the etiology. By the time you've arrived on the scene, they already have had their etiology that's causing their status. You can't change their age. What you can change is their seizure duration. And that's why we concentrate on seizure duration by stopping the seizure to provide the best intervention. Some common etiologies or causes in adults are low anti-epileptic drug levels. So presumably that someone already has epilepsy, their drug levels fall because they stopped taking it or for whatever reason, then they have status. If they've had a previous central nervous system insult, especially stroke, about half of patients over age 60 who have status have stroke as the cause. It can be epilepsy, so even if they don't have low anti-epileptic drug levels, they just have a history of epilepsy, status may come out of the blue. And then acute brain insults, things like stroke again, so not something they had in the past, but active stroke or metastasis of tumor or infection. But in children less than age 2, it's a different story. It's often infection with fever, which is really just one prolonged febrile seizure, which you can imagine is something that's not so bad. It tends not to cause injury or death. In those greater than 2 years old, now all of a sudden it gets back up into similar etiologies for adults, like epilepsy, low anti-epileptic drug levels, and remote symptomatic causes, meaning remote brain injury. This is just to illustrate that the mortality is determined by the etiology. So you can see that the etiology-specific mortalities in the graph listed on the right side, and that the mortality is about 70% in those that have anoxia and hypoxia. That's the first column listed there in the graph, so it's almost 70%. Whereas for stroke, listed as the third one over as CVA in the graph, it's about 41%. So that's still a lot of people who die. But there does seem to be a residual mortality due to status epilepticus alone. In other words, it's not just the underlying thing that causes them, like their stroke or MI, myocardial infarction, but instead it's due to the status itself. So for instance, about 20% mortality occurs in those who have idiopathic status epilepticus, and we don't know why they had it. And about 10% mortality in those who have a remote cause. So they might have had a stroke 2 years ago, so they shouldn't die from it now. So if they die now in that 10%, we presume it's due to the status. And finally, there's an age and etiology interaction in which there's low mortalities in children because children have etiologies that are less likely to kill you. Seizure duration is an important determinant, though, as we talked about, because mortality increases dramatically with longer duration, increases dramatically when the duration exceeds 30 minutes. And the continuous EEG seizure activity has a higher mortality than intermittent seizure activity, not surprisingly. And of course, the problems that convulsive status epilepticus cause tend to happen in two phases. Initially, there's this big sympathetic overdrive, and later there's return to relatively normal function or normal homeostasis. So that acutely, right during the first part of the status, there's fever, which tends to cause certain injury to certain parts of the brain, like the cerebellum, hippocampus, and the cortical areas. There's also a tremendous sympathetic surge that affects the heart, which can be potentially fatal. So potentially fatal arrhythmias occur in more than half of patients with generalized convulsive status. And that means there's an acute decline associated with atherosclerotic risk factors. So in other words, if you have a heart attack and then you have status as a result, you're pretty likely to die acutely after that. It changes respiratory function because of acute pulmonary edema as well as central apnea, so sometimes people just stop breathing during status. Remember, that's fundamentally different than I said during a single acute seizure, in which respiration is not really a problem. And finally, causes acidosis from lactic acidosis because of that extreme muscle activity. There are also neurological complications that occur later, and we're mostly concerned in the acute setting with preventing death and stopping the seizure activity, which we hope stops the neurological complications later, like focal neurologic deficits, cognitive changes, and the later development of epilepsy if they didn't have it to begin with. So we can summarize the epidemiology and pathophysiology as saying that prolonged seizures should be treated as GCSE, that GCSE has high mortality that depends on the age of the person, what's causing it, and the duration of the seizure, so time is of the essence, especially the first 30 minutes. Now let's turn to the objectives of therapy. The first thing that needs to be done is address the ABCs, of course, because when you arrive upon the scene, you don't know if it's a single acute seizure or if it's been going on for 4 hours often. So you have to address the ABCs first. Then it's to stop clinical and EEG seizure activity. And by the time they're in the ED, the emergency department, to investigate the cause of GCSE and then prevent additional seizures. There's a traditional approach that's outlined here, and the traditional approach was to wait and observe for spontaneous cessation. So when you came upon the scene with someone seizing, you were supposed to wait 5 minutes. Then you're supposed to give lorazepam or diazepam twice. That would take about 10 minutes. Then if that didn't work, start to administer phenytoin. That would take at least 20 minutes. And if that didn't work, then give phenobarbital. Now, based on what I just said, you can see the fundamental flaw in this plan. The flaw is that if you did all that, you've already spent more than 55 minutes after you came upon the scene providing treatment. And we said that after 30 minutes, mortality goes way up. So you're really putting them at risk for dying. It wasn't until after this time they were considered refractory. But of course, all this time has passed beyond the time of tremendous increased mortality. So consequently, although many people still think this, there is an emerging, or now I say new standard of care for treatment of status epilepticus. And the contemporary approach is very simple. So instead of remembering all those complexities, it's very simple. When you arrive upon the scene in someone that you think has impending status or has status epilepticus, the first-line therapy is lorazepam, repeated once. That'll take you about 10 minutes. Usually that means 8 milligrams doesn't work, another 8 milligrams doesn't work, move on to second-line therapy. And second-line therapy is either midazolam or fosphenytoin. Typically in the rescue squad, you wouldn't necessarily be able to give midazolam or fosphenytoin, so consequently those are typically ER procedures. So the urgency then is providing lorazepam urgently and an adequate amount, and then transportation to the hospital where